Hi, today I'm here with Dr. Alison Bozung. Dr. Bozung practices at Bascom Palmer Eye Institute in Miami, Florida, lucky her, primarily in the Ophthalmic Emergency Department. She also serves as co-director of the Optometric Student Externship Program. Prior to joining Bascom Palmer, she was a clinical assistant professor at the University of Iowa Hospitals and Clinics in the Department of Ophthalmology and Visual Sciences, practicing in the Cornea and External Disease area, as well as Comprehensive Ophthalmology services. Dr. Bozung received her Doctor of Optometry degree from the Southern College of Optometry in Memphis, Tennessee. Upon graduation, she completed a residency at the Bascom Palmer Eye Institute, University of Miami Miller School of Medicine. She's a member of the American Academy of Optometry, the American Optometric Association, the Florida Optometric Association as well. Dr. Bozung is a sought-after lecturer and author on ocular disease topics and serves as a co-editor for the Review of Cornea and Contact Lens. So welcome, Dr. B. I'm so happy to have you here. I've been following your career.
Thank you so much for the invite.
Oh, my God. Alice and I last saw each other while lecturing at Tropical CE in St. Kitts, beautiful St. Kitts. For anybody who hasn't gone on Tropical CE, that's Jill Autry's trip. I strongly recommend it. Not only is it great education from people like Dr. Bozung, but you get to meet great people too, which we did. I remember one thing about the trip. I tried to teach you craps, and I think you had fun. Have you been back to a craps table?
I have not yet, but it's definitely in the works. Once things open up more, I feel like I'll be going back. But I did win $80 that night from your craps lesson. So
You know, you always win the first time, and that's what suckers you in to start losing. So maybe COVID was a blessing in disguise. As long as
probably I'd be like on a street corner somewhere living in a box, probably.
as long as it didn't become a problem for you, and then you were doing online craps. But I was just checking in, Good times, good times.
Yeah, thanks. Always a good friend.
So can you tell our viewers where you're from, where you went to school, although we said it in the bio, but a little bit about it, and your experience working at the famed University of Iowa Department of Ophthalmology?
Absolutely. So I grew up initially in South Dakota, so I am a Midwesterner at heart and sometimes by accent as well. And I went to school in Nebraska for undergraduate and then went to Memphis, Tennessee, of course, for optometry school. And then after that, again, the bio stated, I went to Bascom Palmer for residency and then was actually kind of landed upon the job at the University of Iowa somewhat serendipitously. So I wasn't trying to get back to the Midwest necessarily. I actually was trying to move out west to like Washington or Oregon. And in that search, I met someone who used to work at the University of Washington, who then worked at the University of Iowa. And it's pretty much one of those small world scenarios where it ended up being that there was no position at the University of Washington, but there was one in Iowa. So I ended up interviewing there and just kind of trying to see what it was all about and fell in love with it. It was a great place to work. I felt super fortunate to have that as my first job out of residency.
It's world famous. When I was working in Israel, the first question that some of the really super famous ophthalmologists asked me over there was like, "Oh, have you ever worked at University of Iowa? In ophthalmology?" And it was the first time I had really been exposed to it. So yeah, very well internationally known as well.
Yeah, absolutely. They've got so many resources. That was, eye rounds is probably the biggest one that people know about, or gonioscopy.org. So they're very, very well known. And without even thinking about it, when you're in school and you're, researching all these things, you're doing residency, you're looking at pictures of different conditions, and you will always come across eye rounds photos, and they're great photos. So I think that's where the name kind of extends out quite a bit as well.
Right, absolutely. Now, from what I heard, and you tell us if this is true, that something about if cows didn't have eyes, you might have never been an optometrist. What's that about?
Yes, that's actually true. Did I tell at some point?
What's that?
I don't know if I don't remember telling you that part, but
Oh, I did my homework. I do my homework for
I
these.
see that. I'm a little bit scared about what's going to come up later in the interview. But no, that's definitely true. So I first was introduced to the eye, I guess you could say, as a potential career choice in high school. So we were doing dissections on cow eyes. And I remember just getting in there, peeling things apart, looking at the structure of the eye and just being absolutely, amazed at how something so complex would function perfectly to create vision for people and animals. And it was basically that was my introduction to, wow, the eye is really cool and maybe I want to study this more. So kind of a unique, I guess, but then once I got to job shadowing a couple optometrists, I really fell in love with the patient interaction and, getting to see everything so close up. That was just it really lit the part of my mind that likes to see the structure function correlation. So I
That,
never really fell away from it after that.
and then I think you kind of parlayed that. My next question was going to be, about you being involved in triage and handling acute problems, but it seems that you're still interested in that, that dissection, that physical, I'm sorry, I'm gonna start that again because I goofed up there. So it seems that you've really parlayed that but with your interest in triage and acute problems on top of just becoming an optometrist.
Yeah, definitely. That sort of, I guess, fell onto me at the University of Iowa first, where it was always an interest of mine, but I didn't know if I would really be cut out for it necessarily. In residency, we saw a ton of stuff, and a lot of it was in different subspecialty clinics that was no longer in the acute phase, but now we're in the chronic disease management phase, which taught me a lot about how things look later on. But I wasn't as familiar, comfortable with what's going on with the initial diagnosis because that kind of sets the whole pathway. And one thing that's really great is that now we've got our residents in the ER with us, our optometry residents, and so I get to teach them what I didn't necessarily learn at my residency. So it's pretty high volume. But to go back to starting at Iowa, when I interviewed there, I think they were saying, okay, well, we have a spot for an optometrist. We're not sure where we want to put you yet. And they kind of asked me what my interests were. And I guess I would give this maybe this recommendation to new grads, and just be open to what you can do with your career, because I basically went into that interview and sat down with, someone from retina, someone from cornea, someone from glaucoma, and kind of went through all the services. And barring two subspecialties, which might remain nameless unless you convince me to give them up, I basically said, yeah, I love glaucoma. I'd be happy to manage glaucoma and the non-surgical cases, and then, work back and forth closely. I also said to cornea, I love cornea, and, I'd love to watch transplants and manage those and long-term, OCP, or, these crazy dry eye cases like Sjogren's. And I kind of went into each part of my interview being open to that. And I wasn't lying. I really do like everything. The only ones I didn't offer that necessarily were to neuro-ophthalmology or pediatrics initially, which now I actually really like neuro too. But it was kind of interesting. So I came into that and they said, we have a good place for you. The cornea department was like, we'll definitely take an optometrist. We could use that. And it worked very well to be kind of, I guess, folded into that service, because obviously we all know that optometry and cornea and transplants work super well together. And then the other part was, we need someone to take on this triage service that we're trying to start, or that it was, kind of morphing into something different. They were getting a lot of calls that were interrupting clinic flow for patients needing to be added on. And they said, why don't we just have you take all the add-ons? And so I was doing, whatever would come in, whoever would call in with an acute problem. I was taking patients transferred from the University of Iowa's ER. They would basically send them over to our clinic. I was also doing some consults for some of the inpatients who were more ambulatory that could be wheeled down to the clinic because it's connected to the hospital. And so it was really a great way to see a lot of acute disease and still have, every subspecialty behind me being very supportive. So I never felt like I was really out on a limb per se.
That's great. That's great. It sounds like you fell into that niche and it was a great fit. I was looking at also at some of the articles, then not only being a clinician or being a great clinician and having these great experiences, but you then parlayed that into a writing career. I've one of the articles I wanted to ask you about was the 6 OCT pitfalls to avoid. How many of those pitfalls, off the top of your head, can you share with our viewers?
Oh my gosh, that was a long time ago. You went back to like 2016, I think,
Long
right?
time ago. That was like yesterday for me.
5 years, man. I just graduated.
Well, you don't have to like
Okay,
quote the
so
article, but what are some pitfalls of OCTs that we want to avoid?
yeah, definitely. So I think one thing that people don't give enough credit to is the choroid. So that's always a hot topic whenever you're at a lecture that talks about OCT, is that people will always get, immediately drawn to the retina. And I think everyone starts at like the RPE and then the foveal contour. And we just immediately look at those. Those are two very recognizable features. But people don't think about the choroid underneath. Now, if the choroid is thick and it's a young patient that has kind of outer retinal changes, it might be something like chronic, central serous. If you see, the macular neurosensory detachment or a PED, it's a lot more obvious. But, kind of looking at the other parts of the OCT that you don't normally give credit to. On the same line, if you think about certain cases that might look like something but really aren't. I think a lot of people get kind of tripped up on maybe things that look like cystoid macular edema. So, we can see VMT that has, traction on the macula, and that's not going to respond to anti-VEGF agents, obviously. So a lot of times you can just monitor those or just watch those. Well, another thing that people get tripped up about looking at OCTs would be things that look like macular edema that really aren't. So off the top of my head, the things I would think about would be something like vitreomacular traction, where the treatment's totally different, right? We're not sending that patient out for an injection, or we're not, trying steroids and NSAIDs for them. That's more something we can maybe watch and see if it resolves with time. Other things like outer retinal tubulations and chronic atrophy of the outer retina and the RPE. And then things like MACTEL, so macular telangiectasia, has some pretty classic findings on OCT that I've seen get referred in for retinal edema and, non-responsive to drops and things like that. So yeah, there are a lot of things that we can,
You did
kind of
good.
up and dig around with the OTs.
You did good. I think you got 4. That's enough for me. I'm impressed. From 5 whole years ago. I wanted to. I was really drawn to your knowledge of trauma and your experiences that you've seen in the ER. I know one of the controversies in acute care of the anterior segment has to do with hyphema and the medical management. Can you update us on the current standard of care or anything that people might want to know about about hyphema and treatment?
Yeah, definitely. So hyphemas, I think, are one of those things where the diagnosis is easy, but the management can be variable depending on the patient. So typically, the first thing that you have to do is, of course, try to rule out any other damage or trauma to the eye. But after you've pretty much decided, hey, if it's just a hyphema, you still, treat that. Typically, you'll be treating with cycloplegics and topical steroids. Now, I think a lot of the discussion lies around what we need to do next. Does this person have to be on bed rest? Does this person have to, stop their aspirin or their blood thinners? There's a lot of questions around those. And I think a lot of it's common sense. For me, if I have someone that has a small layered hyphema, like maybe a grade 1, or especially, just at the bottom starting to layer, I'm not going to say that person needs to be on bed rest. Quiet ambulation is good, but being reasonable about it. Now, if you have someone that has a larger hyphema, someone who's more high risk, like a child, who might not necessarily understand that they need to take it easy. You have someone who has sickle cell, for example. Those patients you need to be a lot more cautious with, both in, what they do around the house, but also making sure frequently, because I've seen a lot of cases where, they might not have had an elevated IOP at day 1, but they come back day 2 and suddenly it went from, 19 to 35 in one day. And so in those patients, we need to be very aware, first of all, if it's a patient of Middle Eastern or African descent, checking in for a sickle cell prep, to be sure we know that if they have, a sickle cell trait or if they're a carrier of any kind. Because that will also affect our management in the way that we watch them even closer. We have them under a microscope because those are patients who are more susceptible to severely high intraocular pressures. But yeah, there's a lot that kind of I think we don't always understand fully. And some of the research, they've done that analysis of our strategy for treating these patients, and they found that a lot of the things that we've always classically done don't necessarily make an impact like we thought they did. And things like people ask all the time if they should stop their blood thinner. And the general recommendation, I think, is not to stop it, because by the time you have someone stopping their aspirin, for example, it's still going to be in their system for a long period of time, probably longer than the hyphema. Right. The other things, people are on Plavix or other medications that are life-saving, and we certainly don't want to stop those just in case, the IOP were to elevate with a worse bleed or something. So we do have to manage those. We have to be aware that they're on blood thinners, but we wouldn't have to stop them.
Yeah, most of the decision making around that is based on the results of controlled clinical trials. That's generally how decisions get impacted when there's standard of care or changes in standard of care. But as far as open globe injuries go, there's not a lot of data like that. How are decisions made in open globe injuries without that real controlled clinical studies backing it?
Yeah, so I would say for me, my experience with open globes is still somewhat limited. I mean, usually what happens when an open globe comes into our ER, they are already triaged by the nurse and seen by a second nurse who's done their entrance testing. By that point, they've already been labeled as an acuity level 1. So for me, an acuity level 1 is either an acute angle closure, a patient who has an open globe that needs surgery. And those are the main two, and sometimes the MAC on RD that will come in would be level 1. And those are basically ones that, as an optometrist, I'm not able to fix that or address their concerns on that day. So the general standard, though, with open globes is, they can still come into the office. And I think we've all probably had, maybe experiencing a couple come in that you weren't expecting, and they pop in the middle of your clinic. Really the main goal of an open globe treatment is the first day trying to get the globe closed and keep the eye from getting infected. Those are like the top two things. And so the patients usually undergo, at least in our facility, they undergo a CT of the orbit so we can assess the globe fully. We will go ahead and usually assess their tetanus status if it was something dirty or metallic that might lead to a tetanus, a bacterial infection. Oftentimes they might get oral antibiotics, not always. It depends on the site of the globe rupture. But after that, really assessing, for the outcome, the study that I think about the most that kind of guides our decision making as far as what to tell the patient for visual recovery would be the ocular trauma score. So you can always reference back to that. But the general thing is, if it seems like it's worse at the beginning, it's probably going to be a worse recovery as far as vision is concerned. And then people get kind of, I think, are surprised that when someone would come in with, a large, foreign body through the cornea, for example, that we're not necessarily going to, take the foreign body out, do a nice, penetrating keratoplasty and close it up, make it look real pretty. The initial surgery is just to close the globe. So if that can be done without going through a transplant, it's probably better that way, so that there's the least amount of intervention at the beginning. And then after that, you see what the outcome is and then what needs to be done after that.
It's amazing like that you're dealing with this stuff, but 90% of optometrists or maybe more would never even consider optometry or would never even encounter. So it's fantastic. Do you on the tail end of that question, you heard about the Cornet corneal implant that just came out, the biomimetic cornea? Have you heard about that?
I have to say, I think I saw it pop up on my feed at some point, but I haven't looked into it myself. You can tell me about it.
Now, but they now have this biomimetic implant that is beyond trials now. I've been thinking Israel, and I think that's going to change the game for a lot of the trauma. But again, we'll wait. Your next time we're going to have you back hopefully, and at that point you'll have some experience with it, and you'll tell us all about it then. One of the things I saw that you write and lecture on a lot are orbital disorders. These are some of the most scary things that walk into an office, or especially in an ER, of course. Can you tell us about a particularly daunting case, any kind of orbital disorder that comes to the top of your head that you dealt with?
Yeah, I mean, there's quite. I actually just put together a lecture, and so the first one that comes to my mind is that one, but I'm not going to do that because I might be giving that later.
Good.
I
Understood.
think, one of the cases that sticks out to me is a gentleman probably in his 70s, and he came in with diplopia, swelling of the eyelids, some pain and discomfort. And he basically walked in, and I immediately saw him, and I thought, okay, this is probably a case of, IOI or idiopathic orbital inflammation or something, because the globe itself didn't look hot. The bulbar conch was not super injected, but he had a lot of inflammation around the eye. And then when I was doing his motilities, there was some restriction. I checked his optometry. He had, proptosis on that side as well. And so, immediately you're thinking of, is this an infection like orbital cellulitis, which, it didn't seem like it based on his review of systems. Is this a tumor or mass? And so you always ask the question, if someone's got proptosis, do you have a history of cancer? Because it could be a metastasis from somewhere else. Then I was thinking, is this an inflammatory disorder? And, more likely the inflammatory disorder would be more common than an orbital met or an orbital cancer. That's kind of where I was going along those lines. But either way, to figure it out, the patient got imaging. And that is one thing that is really awesome that we have the ability to do at our ER is we're actually fully stocked and loaded with an MRI and a CT in our basement. So if we need an MRI for someone, which is every single day, pretty much we're using it, we can just send them downstairs and be like, oh, we'll see you back when you get your scan done.
Sure makes
So
things
they leave.
easier.
Yeah, absolutely. We don't have to deal with prior authorizations and things like that.
Right.
And he basically came back, and I was pretty surprised at what we saw. And he actually ended up having a large mass in the orbit, like very large mass in the orbit that was thought to be probably some tumor, cancer of some sort. And so the crazy part about, and I didn't say this earlier, was that he was actually at the hospital. He was only in Miami for a vacation. He had gone with him and his wife to visit from Texas. His wife was currently in the hospital because she had slipped and fallen down a flight of some marble stairs,
Oh my God.
slipped a disc in her back. So she was actually admitted already, and he had been visiting her. It was actually pre-COVID. So he was with her, and he thought, as he was there, for a couple days, his eyes started to bother him more. So he came in. So he walked himself over to our clinic. And so I'm like, this is the worst vacation for these guys. She basically broke her back, and then we diagnosed an orbital tumor on him. So he ended up getting treatment and follow up closer to home, which was good for him. But it was kind of a scary and very unexpected, diagnosis, and that was within my first couple of months starting. So,
wow. And now they're dealing with COVID, so things did get worse. I'm sorry, sorry to hear that, but it got worse for all of us.
yeah,
So
yeah, definitely.
you mentioned that one case you were going to talk about. It sounds like you're going to put that in a paper or a lecture. What else is next from Dr. B? What can we look forward to in terms of lectures or publications?
Well, if you can look forward to it, that's great. That makes me feel good. If you're dreading it, there's still some stuff down the pipeline here. I'd say basically today was, the day for Academy submissions for lectures. So, you throw your name in the hat for a couple of those. One talk I'd be really, really stoked about is a talk that I've submitted with a couple of other doctors who are all way cooler than me. So John Gellis and Scott Hausworth and Aaron Bronner. So we've teamed up to put something together, and it would, whenever, we'll give it at some point. I don't know if it'll be Academy, hopefully, but it'll be entertaining. So that's one, writing a couple pieces about, pain in the eye and sources of pain, from the orbit and the eye itself, which is kind of a cool topic or a cool lens to look at it through. Those are the main things. Yeah, that absolutely wasn't intended. But thank you for calling me out. A couple things.
So, and beyond that, like, we're going to wrap up soon, but I did want to bring up the fact that you have a wedding coming up, and I was sorry to hear that you had to postpone it. Are you ready? Is it going to go off this time? Let's hope.
That's a loaded question. You know that.
I don't.
Well, hopefully, we're kind of, firing on half of our cylinders right now. I'm ready, yes, and I was ready last June as well. But
Right.
yeah, my fiance is he's actually in Miami too. He also works at Bascom Palmer. You met him when we
Andrew.
were kids. Yeah, yeah. So he came with, and he's an oculoplastic surgeon, obviously. So he's got a lot of stuff going on, and but basically we've tried to kind of hold the excitement back in case it doesn't happen the way we want it to. But yeah, we're it's going to be a go. I just don't know what it's going to look like. It could be just us two, it could be 30 people. I'm not really sure at this point, but
Yeah, you might want to just invite the extra people who've been vaccinated at that point, just to fill it up, right? that might be something you
yes,
could do
yeah.
to make it right.
We'll see. Everyone just out, throw your card at the door, I guess. And no,
That's right.
we'll see. We'll see.
Well, I'm excited for that. It was great to meet Andrew. He's a real nice guy. We had a good time there hanging out. I want to thank you for being here today and tell you that I know you took time out of a busy schedule to make this happen, and I appreciate that. And I think the industry has so much to learn from you. You're young in your career, and you've got so much more to give. And I look forward to seeing you in 5, 10 years from now, and what you're bringing to our education and to the journals and everything. So thank you, and I really look forward to the next time we see each other in person.
Awesome. I look forward to that as well. And I'm really thankful for the opportunity to be on this show. I didn't think I was as cool as your last guest, so that was kind of an exciting thing for me to be me to be invited.
I don't know. You're being modest. I think other people might think differently. With time, people get cooler sometimes, but that'll definitely happen to you. I got guests coming on. Some of the names you mentioned today that you were partnering with, so we're
All right.
excited for all of them. But you were particularly exciting because again, the things you do are incredible. So thanks, and let's connect real soon. Okay.
Yeah, looking forward to it.